Nope, not this slideshow. All right, welcome everyone to our version of the respiratory system. I'm going to go ahead and minimize that. Okay, that looks pretty good. All right, so welcome everyone to our Zoom respiratory system lecture. So today we're going to be talking about both the anatomy and the physiology of the respiratory system. And we're going to be talking in detail about the major events that are going to cause us to inhale, to exhale, and the process of gas exchange, which is really what's happening when we're bringing in the air from the outside and exhaling all the off gas, basically, that's coming from our blood. We'll talk about how oxygen and carbon dioxide are transported in the blood, and I know we touched on that in our cardiovascular lecture, but we'll further emphasize this here when we talk about the principles of gas exchange. But before we do that, how do I move on? All right. So before we do that, let's talk about breathing and respiration. So breathing is the actual act of your lungs expanding, etc., and the gas going back and forth. The respiration is the exchange of the gases between the atmosphere, which is the external environment, and the blood and the cells. So that's actually going to have to go across a membrane to get picked up, and we'll talk about how that works in a second. There are three major processes that have to occur in order for the process of respiration to occur. So ventilation, and as I mentioned, that's breathing, just bringing air in and sending air out. And then we're going to have respiration in the lungs. It's called external respiration. And then we're going to have respiration in the tissues. That's called internal respiration. And the cardiovascular system works along with the respiratory system to transport the gases to the sites of gas exchange internally. In the tissues, that is. If we're looking at the respiratory system anatomically, we have two parts, the upper respiratory system and the lower respiratory system. But if we're looking at it physiologically, we have two major zones. One is the conducting zone and the other is the respiratory zone. Conducting meaning that it's just funneling the air in, and two being the area where respiration actually occurs, or the process of gas exchange occurs. So this here is our respiratory system. The gas is going to go in through the nose or the mouth and head down the pharynx. It's going to pass the larynx, go into the trachea, right? The trachea is going to split into the bronchus. There's two of them, so they're each one is called a bronchus, the dual bronchi, and they feed into the lungs. From the lungs, then we're going to have the process of gas exchange themselves, and we'll talk about how that breaks down a little bit further when we actually get down to that anatomy. Baby, mom's teaching, okay? We're talking about breathing. So the anatomy of the upper respiratory system consists of everything that would be in like the upper head. So your nose, your pharynx, and all of those associated structures. But as soon as you enter into the larynx, I'll go back a second. So that's here. Basically, as soon as it enters past the back of the mouth and into the throat, now we are talking about the lower respiratory system. And that consists of the larynx, the trachea, which looks right here, the bronchi, and then the lungs themselves. So this is a little bit more about the anatomy. A lot of this should look familiar. So we've got a sagittal section. Okay, baby, you can stay in here, but you have to be quiet, okay? He wants to listen to me talk. All right, so the air is going to come in here through the nares. Here's the external nares. Let's enter into the nasal vestibule. We've got the nasal concha directly after that. We've got the superior, middle, and inferior nasal concha. And then we also have the nasal meatus, which are here, the superior, middle, and inferior, and they're going to be at the very end of the nasal concha. Then we're going to enter into the internal nares. This here's the nasopharynx. Here's the auditory tube, which is going to go, remember we talked about the special sense of hearing. That's going to be go up to the what's eustachian tube and allow us to equalize the pressure in our ears. Then we'll head back to the throat. There's a little dangly thingy at the back of your throat, right? That's going to be, it's going to be what you can see that's called the uvula. And then, so when you are going to open up your mouth, for example, and see it kind of dangling at the back, that's called the uvula. Of course, air can also go in here through the mouth and the oral cavity. And my point is that this is all the upper respiratory zone until we enter into the laryngopharynx and into the larynx itself, which is here. The larynx is going to be where we have our vocal cords. We have a true vocal cord and a false vocal cord. So we have a vocal fold, which is our true vocal cord, and then a vestibular fold, which is a false vocal cord, which lies just superior to the vocal fold itself. And then as we enter down, we're going to enter into the trachea, which is then going to split to the bronchi and then into the lungs. 3 major regions of the pharynx include the nasopharynx, which is going to be this area here, all the way up until we enter into the oropharynx, which is oro being the back of the mouth. And then we're going to enter into the laryngopharynx down here at the bottom, which would be where we have the larynx, and the laryngopharynx is here. Okay, so laryngopharynx, nasopharynx, and I'm not sure where it shows the, and the oropharynx here. All right, so let's talk about the nose for a second. So the nose is made of cartilage and skin, and inside it's got a ton of mucous membranes. We talked about that when we talked about olfaction. We also talked about that a little bit when we talked about like immunology and how it has all those hairs that are meant to trap things, and the mucus is meant to keep those foreign invading organisms out. But inside here we have cartilage. We have the septal cartilage, just going to run right across in the middle here. On either side we have the lateral nasal cartilages, and what makes the actual nose openings are these alar cartilage regions. And then at the very edge here, this is not cartilage at all, but dense fibrous tissue and adipose tissue. So you can actually collapse those sides of your nose there, and you can feel there's no cartilage. Again, inside it's lined with the mucous membrane. That mucous membrane is going to secrete fluid that's going to help capture and attack any foreign microbes that might be coming in during the process of respiration.
You should see who I got.
Buddy, I'm teaching. I need you to be quiet, baby. Sorry. All right, so the bony framework of the nose is formed by multiple different bones, including the frontal bone, the nasal bone, and the maxillary bones. And this is, I think I've already walked you through this. I don't think there's anything new here. Yeah, I've already walked you through this diagram here. So the bones that we'll be looking at are going to be the frontal, nasal, and maxillary bones. All right, so this diagram shows the nasal concha and meatuses. So remember, the concha are going to be these folds in the center, and they're going to terminate at the meatuses. So here is the inferior nasal concha, and then here's the meatus right there. And here's the superior nasal concha and the superior meatus right there, and the middle nasal concha and the middle nasal meatus right there. We're also going to be able to see the sinus cavities here. Here's the maxillary sinus. Another bone of interest here is the vomer. That vomer bone is going to go right down the center of that nose, the septal region. Here's the nasal septum itself. Hold on, there, nasal septum. And then as we head upward, we're going to enter into the actual head cavity, right? The brain itself is going to be housed in here. Here we're doing this is the optic nerve, so we're going to actually be seeing where the information is coming from our eyes into our brain as well. What else is here to show? Okay, so headed down into the mouth. Here's our hard palate. So when you press your tongue against the top of your mouth, you've got a hard palate, and towards the back a soft palate. So here would be the hard palate, and here's the tongue where it would press up against it, just to kind of give you the orientation of what you're seeing. And again, the nasal concha are going to be located here, superior, middle, and inferior, and they're going to be surrounded by the meatus, or meatuses. All right, if we're looking at this, yeah, I did. If we're looking at the surface anatomy of the nose, the roots would be right here up in between your eyebrows, and that feeds into the bridge. And at the very end of that, we have the apex and the external nares. And oftentimes when people have like a nose job or rhinoplasty, they're correcting something that's either wrong with this bridge region, there's a bump or a hump or something, or this external, this apex region here tends to also perhaps have an extra sag of skin or something like that. So oftentimes that's what's going to be corrected if someone wants to undergo like a rhinoplastic procedure. So yeah, I talked about all of that. This root is, again, the area where the nose attaches to the frontal bone here. So it's actually going to be a connective region. And again, the apex is the tip, the bridge is the connective region, and the external nares is where we're actually going to have the opening where air is going to be flowing in. So that's for gas exchange. Okay, so the pharynx is going to be the whole area that's a passageway for both air and food, right? So we talked about that when we talked about well, we haven't, I guess, gotten to digestion yet, but we will talk about that when we get to digestion. But additionally, it's going to provide a resonating chamber, so an area where your speech is going to be able to kind of bounce around so that the sounds are going to be amplified. It also houses the tonsils, and we talked about tonsils when we talked about immunology. Tonsils are going to be a region where we're going to be able to have T cells and B cells and macrophages that are going to be available to be able to destroy any foreign invaders that might be coming in through the oral cavities or nasal cavities. And again, the nasopharynx is going to start at the nose, at the very back of the nose, and head to the top of the mouth. Then the oropharynx starts at the very top of the mouth and heads to the laryngopharynx. The laryngopharynx is going to be at the bottom of the mouth and head down. And then after that, we're going to get into like the larynx and the trachea. So the larynx is going to be the voice box. This is what allows us to have speech. It's going to connect the pharynx and the trachea. And here's a lot of things that we have talked about in multiple different, for example, here's our parathyroid glands, we just talked about the endocrine system. And we have the hyoid bone, which is the only free floating bone in the body. It's going to be the only bone in this region. The rest of it is all going to be cartilage. So we have the epiglottis, which is also going to be cartilaginous, right? It's going to have a leaf here and a stem. Remember, that's going to be able to flip to allow us to swallow food, whereas normally it's going to be open such that we're able to undergo breathing, which is going to be kind of our default. Here we have the thyrohyoid membrane, which is going to connect that this hyoid bone down into this thyroid cartilage here. So that thyroid cartilage is known as the Adam's apple. It's more prominent in men. And then we also are going to have this corniculate cartilage, which comes up here and is going to then be connected to the corniculate cartilage is the very tip. It's connected to the arytenoid cartilage. As we head down, we have the cricoid cartilage. If you ever have seen them do like a criciotomy, right? You say, oh, I got to put a cric in and some sort of like a Chicago fire or that sort of thing. Yes, you may, babe. Where they are going to intubate somebody on the side of the road in some sort of accident. They'll call it a cric is one, and then they also could do a trach is another place. So there's a couple different places that they might place that hole. If they did it at cric, it would be right in here somewhere. Don't quote me exactly on it, but it's further up than a tracheotomy, which would be a little bit further down. Again, thyroid gland, at the very back of the thyroid gland, we have those parathyroid glands, and then we have these rungs of tracheal cartilage. So as I mentioned, if you were going to do a tracheotomy, you would pick one, I believe one in here is usually where they do it, the third to fourth one, but don't quote me exactly on that. Anyway, my point is that all of this is cartilage and it's collapsible, which allows it to be able to be flexible and to end up, if you imagine if it were going to be something that could puncture you, if you were to break it, that would be bad. So it has to be flexible. All right. So again, the larynx is your voice box. It has specialty folds called vocal folds, and they resonate and to produce sound when they vibrate. So as you send air across them, you can make specific sounds. And then we emphasize those sounds further with our tongue and our lip to be able to produce speech. So again, this is all the same stuff that we saw previously. Here's our epiglottis with the leaf and the stem. Here's a cuneiform cartilage. The cornicate cartilage at the very top and the arytenoid cartilage going down, and then we end up hitting that cricoid cartilage and then into the tracheal cartilage rings. All of those are connected by ligaments. So here's the cricotracheal ligament, which is right between the cricoid cartilage and the tracheal cartilage. Here's the cricothyroid ligament. Again, it's going to be right between the cricoid cartilage and the thyroid cartilage. And here is our true vocal fold, for true vocal cord. This is our vocal fold. And here's our false vocal cord, the vestibular fold here. There's a little bit of fat that's going to surround that little thyrohyoid membrane that's going to be found right underneath, again, that hyoid bone. So all of that we've already discussed, but that's just showing you in a different section. This is the sagittal section here. If we're going to look at it in the frontal section, we're going to see all the same things. Here's our epiglottic cartilage feeding down into our laryngeal vestibule, which just is going to be the opening to the larynx. Here's the rima vestibuli, which is the region that allows the air through. And there's the laryngeal ventricle right here. And that's going to lead directly into the infraglottic cavity. Surrounding that, we're going to have the same cartilage that I've shown you previously. So here we have the thyroid cartilage on the top, the cricoid cartilage going down, and then the tracheal cartilages. Remember those three rings that are found here. Surrounding that, we have the thyroid gland, and then those 4 parathyroid glands around that as well. If we're looking at the muscle, here's the thyrohyoid muscle, named because it's going to surround that the thyrohyoid membrane, etc. Then we're going to have, as we're looking through here, here's our vocal cords. Here's our false vocal cord. It's just superior to our true vocal cord, which is our vocal folds. We also have the vocalis muscle, which allows us to move that just a little bit so we can decide whether or not to speak or just to breathe, right? And then some other muscles found in here include the inferior pharyngeoconstrictor muscles, the sternothyroid muscle, and then this is the lateral cricoarytenoid muscle. And again, these are just basically named on the regions that they connect, right? Because this one's going to connect the crico region to the arytenoid muscle, arytenoid cartilage. And then, oh, I've already talked about this. Then we've got the thyroid glands with the parathyroid glands behind it. All right, so let's move on from the larynx. So let's talk about how we actually create our voice, right? How do we create sound? So again, if we look at the cartilaginous layers, here we've got the thyroid cartilage. Moving down, we've got the cricoid cartilage. And those are connected here by this vocal ligament. And that vocal ligament can go inward or outward based on whether or not we have flexion or have tension on this posterior cricoarytenoid muscle. Now, a laryngeal scope is something that you would put down someone's throat that would allow you, it's kind of like a camera that would allow you to see what's going on in the larynx region. And this is what you would see. You would see the very back of the tongue and past the epiglottis, right? Here we would see the vocal folds. And around that we'd have the vestibular folds here. So here's the false folds and then the actual vocal folds. And then again we have the cuneiform cartilage. There's cornicate cartilage, which is here covered so you can't really see it, but you could see it. The cornicate cartilage is going to be the one. Let me go back one here. Let me go back one more. That's going to help you here. So the cornicate cartilage is going to be the one that's at the very tip there of the arytenoid cartilage. All right, going back forward. And so that's what you're going to see here, but obviously it's going to be covered with tissue. Now we're able to move those vocal cords together by this lateral cricoarytenoid muscle, and that one is going to have flexion. Then we're going to be able to have these pulled together, right? So it's basically going to be pulling this part outward, and when this part moves outward, these guys move inward, and that's going to look like this through the laryngeal scope. And so we can move the vocal cords apart or together, and the opening as well as the type of vibration, right, how much air you're going to put through, compounded of course with your tongue and your lip, is what's going to create speech. All right, so the trachea is going to be the wind tube, right? It's going to extend all the way from the larynx down into the primary bronchi. We're going to have a left and a right bronchus. So here is the trachea. The trachea is going to lie just adjacent to the esophagus. And here we are taking, so there's a transverse plane. So remember that the trachea is going to have cartilage, so it's going to be popped open most of the time, although it is able to be, it's going to have a little bit of flexibility to it. The esophagus is only going to need to be open when we're actually swallowing food. So most of the time, the esophagus is going to be essentially collapsed, where it's only going to need to be able to open when we're actually in the process of eating. But the trachea is going to need to be open almost all the time because we're breathing constantly, right? So that's why it's going to be supported by these tracheal cartilage. Here's again is the thyroid gland on either side, the right lateral and the left lateral lobe. Okay, as we head down the trachea, we're going to enter into the bronchi. We have the left and the right main bronchus. Those are here. Here's the right main and the left main bronchus. As we head let's talk about the outside as well. So the outside, we're going to have, remember when we talked about the pericardium, we had the visceral and the parietal pericardium. We have the same thing here with the pleura of the lungs. The visceral is going to be on the inside, and the parietal is going to be on the outside. And in between that, we have a pleural cavity. Now, we're going to have 3 main lobes on the right side and 2 lobes on the left side. We also are going to have what's called the cardiac notch. So anatomically, this is where the heart would sit, and so that the lungs are going to kind of move around that to accommodate it. But let's talk about what happens to the actual air, right? So the air comes down the trachea, it splits into the right and the left lungs, or sorry, right and left bronchus. Then they're going to travel into the lobar bronchus, which then travel into the segmental bronchus and into the bronchioles. From the bronchioles, they are going to go into the terminal bronchioles. And we're going to see the same thing here on the right. One thing I haven't mentioned yet that's very important in the actual act of respiration is this muscle here. And this muscle here is called the diaphragm. And the diaphragm is what allows us to breathe. When we have the diaphragm pulled downward, that's going to mean that the lungs are going to want to expand. And when they expand, they're going to want to pull air in. And then when the diaphragm moves upward, that's going to compress the lungs, forcing air out. And those actions back and forth are what's going to be actually creating tidal exchange or exchange of your gases, right? All right, so again, as the air enters into the lungs, it enters into the trachea and then down into the main bronchi, again, the left and the right. Each one of those then split. We have the lobar bronchi, then we enter into the segmental bronchi, into the bronchioles, and the terminal bronchioles. And just like the branches of a tree, these get further and further fractured down until they reach every region of the lungs. Now, the terminal bronchioles themselves are the end of the conducting zone. So remember, we split it previously into the upper and lower respiratory system, but we also split it up into the conducting and the respiratory zone. The conducting zones are the highways that get the air to the site of gas exchange. The site of gas exchange is not going to occur until we get past those terminal bronchioles. All right, this I've already talked about. I did talk about the pleural membrane as well. This is not the slide I expected to see here, though. We'll get to what I expected in a second. So, again, we have the visceral and the parietal pleural. So the parietal pleural is going to be on the outside, the visceral is going to be on the inside, and in between those is the pleural cavity. And similar to the heart, which remember is constantly beating and we want to be subjected to the least amount of friction possible, the lungs, which are constantly breathing, are going to want to be subjected to the least amount of friction while they do that possible as well. So that pleural cavity here is what's going to allow the lungs to expand and contract without encountering massive amounts of friction. From the cardiac section, here's our ascending aorta and our pulmonary arteries, our pulmonary vein, where we're going to have return back into the heart. Here's the esophagus, and here's the aorta as well. All right. So as I mentioned, the left and the right lungs are going to have different lobes. So the right lung has 3 lobes, and the left lung has 2. Here's the oblique fissure and the horizontal fissure. We're going to have 2 fissures in that right lung. We're only going to have 1 fissure, the oblique fissure, in the left lung. And don't forget, we're also going to have that cardiac notch in that left lung as well. So when I talked about, remember we talked about with the heart that the blood was going to go from the right ventricle back out to the lungs and then come back in from the lungs into the left atria. That's what's being shown here. We're going to see how the blood is actually going to be pumped out of the heart into the lungs where the site of gas exchange is going to occur. They're going to get oxygenated and then they're going to come back in. All right, so that's what happens if we look at it from a medial view. You're also going to get to see all of the different, the hilum, which is going to be the roots of the pulmonary pathways for the blood supply. All right, so this is what I thought I was going to hit 3 slides ago, so I apologize that my banter got kind of broken off here. So after we're done with the conducting zone, which again ends at the terminal bronchioles, we're going to enter into the respiratory zone. Now the respiratory zone is going to end up at these things called alveoli. Alveoli are tiny little air sacs. They look like bundles of grapes, perhaps, bunches of grapes, and they're found within the lungs. These are going to be microscopic. So once we hit the respiratory bronchioles, which is where we're going to go after the terminary bronchioles, enter into the respiratory bronchioles, into the alveolar ducts, the alveolar sacs, which again terminate at the alveoli. And again, alveoli are small little sacs. They look kind of like grapes. So here's the lobule of the lung. Here's going to be the terminal bronchiole. From there, we enter into the respiratory bronchiole, into the alveolar ducts, into the alveolar sacs, and eventually into the alveoli themselves. So here's a diagram of that. Same thing. We're going to have the terminal bronchiole here. Then we're going to have the respiratory bronchiole. So it's the very beginning of respiratory exchange. And then we're going to enter into the alveolar ducts, depicted here, into the alveolar sacs, which is eventually going to terminate in the alveoli. So these are sac-like structures where we're actually going to have gas exchange occurring. And what's happening in those alveoli? So we have here's the alveolus, right? Here's just one. We have 2 major types of alveolar cells, type 1 cells and type 2 cells. And these guys are going to be involved, again, in gas exchange. So here we have the alveolar fluid, which is going to have a specialty biomolecule called a surfactant. And a surfactant makes water wetter, if you will. It's like when you add makes things slippery or a little bit less viscous. And what that means is that we're going to allow for gas exchange to occur more quickly across this membrane because of that alveolar fluid that has that surfactant in it. And what's happening is we're going to have the diffusion of the carbon dioxide coming out of the blood and diffusing in that oxygen, which is then going to get picked up right by the red blood cells. Remember, the red blood cells are what are transporting these gases to this site of respiratory exchange. Right, and that's all going to happen across that capillary endothelium into the epithelial basement membrane across that type 1 alveolar cell. So that type 1 alveolar cell is actually going to be involved in gas exchange. We also have type 2 alveolar cells. These are septal cells. We'll talk about what they do in a second. So yeah, the respiratory membrane is going to be comprised of these type 1 alveolar cells. We also are going to have macrophages present, which is going to be really important, right? This is in direct contact with the external environment. So we might have different invading microbes, etc., that are coming in from the air.
Mom.
All right. So the respiratory membrane, as I mentioned, is comprised of those type 1 and type 2 alveolar cells, and also any alveolar macrophages, and that's going to constitute what's called the alveolar wall. And underneath that alveolar wall, we have an epithelial basement membrane, and we also have a capillary basement membrane, fused most of the time, fused to that epithelial basement membrane. And then we have the capillary endothelium. So that's all of those layers are going to be what's comprised, or what the respiratory membrane is comprised of. As I mentioned, so blood is going to leave the heart and enter into the lungs via the pulmonary arteries. This is called pulmonary circulation. It also is going to enter through the bronchial arteries. That's called systemic circulation. And we have blood that exits the lungs, that exits out through the pulmonary veins and the bronchial veins. And we have something that occurs called ventilation perfusion coupling. So ventilation would be the actual act of bringing in and out gas, and perfusion would be getting things infused into the actual liquid, right? So that's, we couple these two together, and we do that by vasoconstriction. So if we have hypoxia or low oxygen conditions, then we can vasoconstrict regions to divert blood from poorly ventilated areas into well-ventilated areas. So if we see that one part of the lung is working better than the other, we will give that part of the lung more blood, right? So areas that are better ventilated will get more blood than areas that are poorly ventilated. Okay, so this table here summarizes the structures of the respiratory system. Those are to include the nose, the pharynx, the larynx, and the trachea. The nose has the vestibular region. The vestibule has a respiratory region and an olfactory region. We've talked extensively about the olfactory epithelium. We've already been tested on that, so all of that should already make sense. The vestibule is going to be a region that's going to have a bunch of hairs and is going to help trap invading microbes, etc. It's all going to be composed of non-keratinized stratified squamous epithelium. And the respiratory region is going to be pseudostratified ciliated columnar cells. And it's going to contain those nasal concha and the nasal meatises that we talked about previously. After we enter from the back of the nose, we'll enter into the nasopharynx. The epithelial here is going to be pseudostratified ciliated columnar. And no, I'm not going to test you on which epithelial layer is found where, but if you think about it, these are going to make sense based on what their function is, right? In this region, we are going to have an air passageway. It's also going to have tonsils, the pharyngeal tonsils, and those auditory tubes. The oropharynx is where we're going to get to as soon as we get to the back of the nasal cavity and enter the top of the mouth. There's going to be a passage for air, food, and drink. And it's going to contain your oral opening, right? Your fauces is what that's called. The laryngopharynx is going to be the passageway for both air and food and drink. Then we enter from the laryngopharynx into the larynx itself. The larynx is going to have specialty cells that are above the vocal folds that are non-keratinized stratified squamous. And then they become pseudostratified ciliated columnar below the vocal folds, because this is where we're going to enter into where we want to be expelling any sort of mucus that might have foreign invaders. So above the folds, we do not have cilia, but below the folds, we do have cilia. And below the folds, we also are going to start having goblet cells. Goblet cells are going to help us secrete mucus. So the larynx is going to serve as a passageway for air. Going to have our vocal folds so that we're able to make sound, so we're able to have our voice. And just beneath that, we're going to enter into the trachea, where we enter into full ciliated and goblet cells. It's pseudostratified ciliated columnar, which is exactly, that's going to start, as I mentioned, that pseudostratified ciliated columnar starts at the lower part of the larynx, just below the vocal folds. And now it's going to be a passageway for air, as well as those cartilage are going to be contained here in the trachea. There's several C-shaped rings of cartilage, which allow us to keep our trachea open so that we can breathe. All right, so all of these that we've talked about have been conducting structures, and the conducting structures are going to continue all the way till here, and then we're going to enter into respiratory structures. All right, so we've come down the trachea. We're going to split into the left and the right bronchi. Bronchi are going to be divided into the main, the lobar, the segmental bronchi, and then we get into the bronchioles, and they're going to descend in order of size, the larger, smaller, and terminal. And eventually they're going to become microscopic, ending in these respiratory bronchioles. Now we're entering into the respiratory structures. Respiratory bronchioles feed into those alveolar ducts and eventually into the alveoli. So again, all of these are going to be passageways for airs. But then as we enter into the respiratory region, we enter into a passageway for air, yes, but also a site of gas exchange. Additionally, the alveolar ducts are going to start producing that surfactant, as do the alveoli. So that surfactant is going to increase the ability of the gas to go across that membrane because it's going to decrease the viscosity. All right, so pulmonary ventilation is when air is coming from the outside atmosphere, and it also is going to enter all the way into the alveoli of the lungs. And it does that by the process of inhalation and exhalation, which occurs by alternating contraction and relaxation of your respiratory muscles. And this in part works because of something called Boyle's law. So the volume of gas is going to vary inversely with its pressure. So as you put gas under pressure, it will get smaller. The volume will get smaller. So for example, pressure at 1 atm will be 1 liter, but pressure at 2 atm will be half a liter. Pressure at 3 will be 1/3. Pressure at 4 atm will be 1/4 liter, right? So it's going to vary inversely with the amount of pressure. And so what that means is that we can use that to force gas one direction or another. All right, so here we have the muscles of both inhalation and exhalation. If you want to just take a nice deep breath right now, you're not only going to feel your external intercostals, right, your rib muscles, as well as your diaphragm. Your diaphragm is going to pull down when you take a deep breath. And that's going to mean your external intercostals are going to pull up, which really feels like it's pulling outward. But also your neck. Can you feel your sternocleidomastoid? Right, your scalenes? Those are actually also going to be pulling upward at that same time, which is going to draw that rib cage outward. And that's going to allow us to have the most amount of air drawn into our lungs as possible. When we exhale, go ahead and exhale as hard as you can. What you're going to feel are the internal intercostals pulling down, so your ribs are actually going to contract a little bit. The only thing that's going to contract is those external obliques. And the internal obliques, you're actually going to feel that in your abs, right? Those rectus abdominis muscles as well. All of that is going to be coordinated with your diaphragm moving upward, such that we're going to be forcing the air outward. And this is going to show you the change in the size of the thoracic cavity during inhalation and exhalation. So here's exhalation, pushing upward, inhalation, pulling downward, and that's going to pull more gas in. And the difference between the maximum intake, when you take your deepest breath, and your maximum exhale, when you exhale as much as possible, that's called your tidal volume. That's the actual amount of air that you're able to press out in one deep breath. All right, so this is going to look like a little bit of math, but it's not really math per se. All you have to do is look at the numbers that are larger versus the numbers that are smaller, right? So here, if we're going to assume that the atmospheric pressure is staying the same, 760 across the board, okay? We have other pressures that we need to take into consideration, including our alveolar pressure and our interpleural pressure. So when we are resting, the alveolar pressure is equal to the atmospheric pressure, so there's no airflow. So in between breaths, when you're not breathing, you're not inhaling, you're not exhaling, you're just kind of at rest, all of these pressures should be approximately equal, right? In this case, about 760. However, when you inhale, that's going to pull that diaphragm down. The external intercostals are going to contract. That's going to mean that the alveolar pressure is going to decrease. When this number is lower than that number, air is going to rush in, right? Everything's going to go from high to low. So that means that the air is going to come in this direction. When we exhale, however, that's going to increase our alveolar pressure above the atmospheric pressure, right? Here we're at 758. That's below that 760. Here we're at 762. That's above that 760. And that means that air is going to go outward. And again, that's going to happen because the diaphragm relaxes. The external intercostals relax. Remember, those are involved in the actual bringing in inhalation process, right? Bringing the air in. That means that the chest and the lungs are going to recoil, including the chest cavity contraction. That means alveolar pressure is going to increase because of that contraction. And once it increases above atmospheric pressure, air is going to flow out of the lungs, and the lung volume is going to decrease. During this time frame of these forced exhalations, the internal intercostals, that's going to be your rib muscles, right? And the abdominal muscles, as well as the obliques, are going to contract. That's all going to reduce the size of the chest cavity further, increasing the alveolar pressure, which would increase the rate at which the gas will be escaping. And we're just going to lather, rinse, repeat through these three different pressures internally and externally while we are breathing. Okay, so this picture is going to talk about other factors that affect pulmonary ventilation, including surface tension, elastic recoil, and compliance. Surface tension is going to be a force that's directed inwardly inside the alveoli themselves, which have to be overcome to expand the lungs each inspiration. So picture this as like when you're blowing into a balloon and there's a little bit of resistance at first, right? How much resistance is there depends on how rigid that balloon is, and that's similar to that alveoli pressure, right? Once you start to overcome that, then you're able to expand the lungs. But it's more than just one balloon, right? It's the amount of resistance that you'd have when you're trying to expand lots and lots of balloons. And again, once you get it started, then it's going to be a lot easier, but it's a force that you're going to have to overcome in order to initiate expansion during each breath. We also have elastic recoil. Elastic recoil is going to be a picture of a rubber band going back into place, or a balloon as the air is exhaling going back into place. That's going to allow us to decrease the size of the alveoli during expiration, forcing the air out of each of the alveoli. And then we also have a measure of compliance, which is how easy is it for the lungs and the thoracic wall to be able to expand. All right, so these are different types of breathing patterns and respiratory movements, including eupenia, apnea, dyspnea. Anytime you see enia, it's going to be either a normal or an abnormal respiratory movement. We also have costal breathing versus diaphragmatic breathing. So if you're breathing with your lungs as opposed to breathing with your diaphragm, you're going to get different inhalation and exhalation capacities. And anyone who's ever taken any sort of singing has learned this, or if you're a free diver, right, you've learned this as well. So these are different types of modified breathing movements, including coughing, sneezing, sighing, yawning, including sobbing. Hey, baby. Sobbing is also on this list. Crying, laughing, hiccuping, and something called the Valsalva Maneuver, which is what you use when you're going to force air in order to in order to be able to defecate. And then also when we pressurize the middle ear, which occurs when you're, say, for example, free diving, etc., or if you're on an airplane and you need to equalize the pressure on the inside of the ear. Typically you do that by holding the nose and the mouth, but you can also employ that Valsalva maneuver that I was talking about previously in order to make this pressure right as well. All right, so this diagram is going to depict lung volumes and capacities. All right. So when you are going to just take your regular breathing, inhaling and exhaling, that's going to be your normal tidal volume. How much do you breathe out versus how much do you breathe in? Okay? But we also are going to have a reserve volume, which is going to be if you're able to exhale as much as possible, you're going to be able to exhale a little bit more than your normal breathing. And if you were to inhale as much as possible, that's called your inspiratory reserve. And that's called your inspiratory capacity is going to be the maximum amount that you're going to be able to breathe inward at your deepest breath. Okay, and so this, it says start a record. This would be if you were to try to do this in lab. We do have something for that, but unfortunately we won't be able to use it because it's not going to be something that is going to be very COVID friendly. Would be breathing into an apparatus and measuring your respiration. But basically what you would be looking at in that is you would take a couple of normal breaths, then you would take your full inhale and your full exhale, and then take a couple of normal breaths, and you'd be able to measure things like your inspiratory reserve volume, which would be your maximum inhalation. And then from that, you can calculate things like your inspiratory capacity, which is basically your full inhale from what you started with at a normal amount of lung volume already. And then again, that exhalation volume to the full amount of inhalation volume would be your vital capacity. How much are you actually able to inhale and exhale? But that's not going to be your full lung capacity, because lung capacity is also going to involve this region here, which is called your residual volume. How much air is in your lungs after you have exhaled as much as possible. So there's a couple different ways that we measure your actual breath, right? Your breathing. The tidal volume is the normal inhale, exhale that you're normally breathing, found here. And then again, your maximum inhale is your inspiratory capacity. From that inhale to your exhale, to your maximum exhale, that is going to be your vital capacity. And the total lung capacity is going to include that plus also your residual volume. Right? And any of this that's on this diagram is all fair game in terms of a question that could pop up on an exam. All right, so let's talk about a couple different types of gas laws. So Dalton's law basically says that each gas in the mixture, remember we're going to be breathing in air. Air is not a pure gas. Air is a mixture of gases. But each gas is going to exert its own pressure as though no other gases were present. So we're not going to be looking at this as a whole. We're only going to be looking at it in terms of each of the individual gases. And Henry's law discusses the quantity of a gas that will dissolve in the liquid. And the quantity is proportional to what's called the partial pressure of the gas. So how much pressure is that gas providing out of the total gas. And that's going to be also factored into something called its solubility coefficient. So every gas has its own solubility coefficient. Don't worry, I won't ask you to calculate any of these, but I do kind of need you to understand that there's a couple of things that are going to play or influence the amount of gas that's able to go into a liquid solution. Again, the pressure of the gas, the solubility coefficient, the temperature, etc. Now, again, we have external and internal respiration. External respiration is when we are having gas exchange in the lungs, where oxygen is going to diffuse out of the alveoli into the pulmonary capillaries, and carbon dioxide is going to move out of the pulmonary capillaries into the alveoli. And then we have internal respiration, where oxygen is going to be diffusing out from the systemic capillaries into the tissue itself. And again, carbon dioxide is going to be coming out of the tissue into the systemic capillaries. So we have two different types of respiration. Respiration that occurs in the lungs, or external respiration, where we are off-gassing carbon dioxide and picking up oxygen. And then also internal respiration in the tissues, where we're going to be delivering oxygen to the tissues and picking up carbon dioxide. Okay, so that looks kind of like this. So here's going to be the inhaled gas. So here's new inhaled oxygen. And we're off-gassing the carbon dioxide. That's going to get exhaled. And this shows you the partial pressure of the gases in the air, in the alveoli, and in the atmosphere. I apologize, move away there. So in the alveoli air here, we're going to have the partial pressure of oxygen 105, whereas in the atmospheric air, the partial pressure is 159. So that means that the air is going to come in from that atmospheric air into the alveolar air, into the actual, cross that membrane into the pulmonary capillaries. That's external respiration, right? Oxygen comes in, carbon dioxide goes out at the pulmonary capillaries. Remember, that's going to happen just after the blood has left the right ventricle out to the lungs. And that's going to be here where obviously that gas exchange is happening in the lungs. And then that oxygenated blood is going to get recycled back into the left atrium, where then it's going to get pumped out into systemic circulation. All right, you'll notice that the oxygenated blood here has a partial pressure of oxygen about 100. So we're losing pressure from the atmospheric air to the alveolar air to the oxygenated blood. We'll lose even more when we get to deoxygenated blood. It's going to get down to 40. So you can see why the oxygen would go from 105 to 40. It would pop right on in. It would get sucked up essentially. Whereas carbon dioxide here is 45. And so it's going to get delivered as off gas because it's only 40 in the alveolar air, right? And again, this is describing both external respiration, which I think I've described pretty well, and internal respiration, which is the gas exchange between the capillaries and the tissues themselves. Remember, we're going to have leakage out of the capillaries into the interstitial fluid, and then exchange from that into the cytoplasm for things like oxygen and nutrients, and then things like carbon dioxide and cellular waste are going to leave those tissue cells and get picked up by the systemic capillaries and cycle out to be able to get oxygenated again. All right, so carbon dioxide and oxygen are going to be transported in the blood. Most of oxygen is going to hitch a ride on a molecule called hemoglobin. 98.5% of the oxygen in the bloodstream is going to be carried by hemoglobin, but some of it is circulating free, dissolved in the plasma, 1.5% of it. Carbon dioxide is typically going to be mainly carried by hemoglobin inside red blood cells, but most of it, like in terms of the red blood cells, it's mainly going to be carried by hemoglobin, but most of it is actually going to be transported as bicarbonate ions, and that's going to be a buffer that we can talk about when we talk about, we talk about maintenance of blood pH. Bicarbonate is a really good buffer to make sure that the pH stays within certain range. And then again, some of the carbon dioxide is going to be dissolved in the plasma. What's interesting to point out here is that hemoglobin is going to have an affinity both for carbon dioxide, which makes it carbonamino hemoglobin, but also for oxygen as well. So hemoglobin, although it has a higher preference for oxygen than it does carbon dioxide, as oxygen goes lower and lower, right, as we go here, starts getting less and less, now all of a sudden hemoglobin is going to want to pick up that residual carbon dioxide. All right, so what affects the binding of hemoglobin to oxygen? Well, the partial pressure of oxygen for one, as well as the partial pressure of carbon dioxide for two, the pH, which again is going to be related directly back to the amount of carbon dioxide in the bloodstream, because the bicarbonate ions are going to be involved in this pH system, the temperature, and the type of hemoglobin that we are using as well. All right, so percent saturation of hemoglobin. So hemoglobin is never going to be fully saturated. It's never going to hit 100. But when it gets to be mainly oxygenated, like as fully oxygenated as it's going to want to be, it's going to be a high 90s. Right? And this is what we want to see in our systemic arteries. And this is actually something that's relevant now in this COVID time frame, because when we talk about desaturation conditions, right, you talk about, oh, they were doing fine and then they entered into desat, and once they hit desat, then it was over, right? And desaturation conditions are going to be once we get lower, I think then it's like high 70s, you enter into a situation where you have deoxygenated blood that's circulating in your body, which means that it's not going to be performing proper gas exchange. All right, but I digress. So the partial pressure of oxygen is measured here, and the percent saturation of hemoglobin is measured here. And as we increase the partial pressure of oxygen, we're going to get more and more and more of the hemoglobin saturated. Again, we're never going to reach 100%, even if we have 100% of the partial pressure of oxygen. We're only going to still be reaching the high 90s. But again, this is going to be good because that means that when we have 90% saturation as it travels through the tissue, it's going to be able to deliver that oxygen to the tissue, where it's going to end up being deoxygenated, right? Here's your average deoxygenated blood in systemic veins. And so if we drop past our average deoxygenated blood levels, well, now we're actually going to be robbing oxygen from our tissues. So again, this would be considered the desat condition that we were talking about when you read about it in the newspaper in terms of COVID-19 affecting your ability to respire and ability to transport oxygen through your blood. All right, so there are a couple of things that affect the affinity of hemoglobin for oxygen. One is the effect here of pH. So here's the normal blood pH, about 7.4. A low blood pH is going to inhibit the ability to pick up that oxygen, so we're going to take a little bit of a delay. A higher blood pH means we're going to pick up that oxygen a little bit faster. We're still going to saturate out, though, around 95. We're never going to really hit 100. Here's the effect of the partial pressure of carbon dioxide on the affinity for hemoglobin. So here's our normal blood. If we have high amounts of carbon dioxide in the blood, we're going to have a decreased response or a lag in our response for our saturation of hemoglobin, right? So we're going to not, because some of that hemoglobin is going to be binding to carbon dioxide, which means we're not going to reach that that peak, which again we're going to be somewhere around here, of oxygen binding. Here we have a blood that has low partial pressure of carbon dioxide, and that's going to have a higher affinity for oxygen, so we're going to reach saturation conditions faster. This one here is showing temperature. So same thing, here's our normal blood temperature. So this is our normal saturation of hemoglobin curve relative to the partial pressure of oxygen. If we have a lower temperature, the saturation of hemoglobin can be higher. And this is going to be something that could be very relevant for someone who ends up dropping into a really cold pool. And instead of drowning, they enter into kind of like a state of a coma. And at that really low temperature, if their body drops very quickly, they actually are going to retain their saturation of their hemoglobin for longer than those of us at normal blood temperatures, right? Even at a lower partial pressure of oxygen, we're going to maintain a higher percent saturation of our hemoglobin, which means those individuals are able to survive for much longer conditions than you would expect them to be able to before they actually reach what we would consider to be drowned. So there's a lot of miracle stories of individuals who fall underneath the ice for several minutes and then are resuscitated, even though normally that would reach drowning conditions. And then here's what happens at higher temperatures. At higher temperatures, we have a lower affinity for the oxygen on our hemoglobin, so we're going to take a little bit longer to reach saturation conditions. Higher partial pressure of oxygen in order to reach saturation. All right, another thing that can affect the affinity of hemoglobin for oxygen is whether or not we have fetal hemoglobin. So maternal hemoglobin is going to be alpha and beta, but fetal hemoglobin is going to be gamma and I don't remember. It's either gamma and alpha or gamma and beta. I apologize, but it's going to have that gamma hemoglobin. And gamma hemoglobin has a higher affinity for oxygen than does the maternal hemoglobin. And this is important because during maternal circulation, the mother is going to already utilize some of the oxygen before it can get through the umbilical cord to feed the fetus. And so that fetus is going to have to be able to pull oxygen from a little bit lower oxygen conditions because by the time the blood supply gets to him, the oxygen is going to be slightly depleted. This is why you hear stories, miraculous stories, of an infant, a very young infant, of course, because they still have gamma hemoglobin for several months. I'm not sure exactly how long, but I believe it's up to the 6-month window. So sometimes you'll hear a story where a young infant will survive a house fire when the parents perish. And again, that's due to the fact that fetal hemoglobin has a higher affinity for oxygen. And so if we're in this range where the fetus can survive, the infant can survive, but the parents will perish, then we have a small, slight window where there is an advantage to those that have the gamma hemoglobin in terms of being in low oxygen conditions. Okay, so this diagram here depicts the exchange of oxygen and carbon dioxide across the pulmonary capillaries. Again, this is going to be external respiration. So here we have inhaled the oxygen, and the oxygen is going to go into the interstitial fluid, across the capillary wall in the lungs, into the plasma, and then get picked up by hemoglobin. Now, at the same time, we're going to have high levels of carbon dioxide, and the carbon dioxide is going to want to be delivered, so it's going to have to get across this membrane to be exhaled, and it does that it's going to be unloaded by carbonic anhydrase. We're going to take that bicarbonate, we're going to break off that carbon dioxide, and we're going to then result in water and the carbon dioxide that can be lost. Additionally, we're going to have a chloride shift, so the chloride is actually also going to leave, and that's going to allow us to deliver that carbon dioxide across the membrane. All right, so on the other side, here's our systemic capillaries. So this is going to be in the tissues. So here we are delivering oxygen. And we're going to do that by breaking that oxygen off in the hemoglobin to deliver it through the plasma across the systemic capillary wall into the interstitial fluid to be picked up by the tissue cell. At the same time, that carbon dioxide has to get picked up. So that's going to go across the capillary wall and get picked up as the chloride also slides in. So that same chloride that we lost, we're then going to pick up from the blood plasma, and we're going to utilize that to be able to use an enzyme called carbonic anhydrase to create bicarbonate. In this way, we're able to store that carbon dioxide as bicarbonate in our system so we don't end up with carbon dioxide toxicity. Again, that bicarbonate is going to get broken down by carbonic anhydrase to be able to create that free carbon dioxide that's going to get off-gassed during external respiration in the pulmonary capillaries. All right, so let's talk about the brain and how the brain is involved in respiratory control. So we have a respiratory center in our brain that's called the pontine respiratory group. It's found just superior to the pons and inferior of the midbrain. We also have the medullary respiratory center, which is found in the medulla. in the medulla oblongata. Here we have the pre-Boltzinger complex, the dorsal and ventral respiratory groups here, and those are again all in the medulla oblongata region, and they're going to send information out through the phrenic nerve. Remember, the phrenic nerve is going to innervate the diaphragm, and also through the intercostal nerves, which are going to innervate the external intercostal muscles, which are both going to be involved in the act of respiration. All right, so the dorsal respiratory group is going to be involved in the control of respiration. So we have active and inactive. So during normal breathing, normal quiet breathing, we have about 2 seconds of active breathing and about 3 seconds of a pause during inactive breathing. So let's talk about active breathing. During active breathing, the diaphragm contracts, external intercostal muscles contract, and then that's going to result in a normal quiet inhalation. We can also then have those 3 seconds of inactivity where the diaphragm relaxes. Those external intercostal muscles also relax or become less active at least. And then we have elastic recoil of the lungs, which directly follows, which causes the lungs to expel their gas. And that results in normal, quiet exhalation. However, during forceful breathing, that dorsal respiratory group is going to activate the ventral respiratory group. So the ventral respiratory group is not involved here in normal quiet breathing. So the dorsal respiratory group does what it normally does, including contraction of the diaphragm, the external intercostals, as well as activation of the ventral respiratory group, which activates accessory muscles of inhalation, including that deep breath pulls up your muscles of your neck, right? The sternocleidomastoid, also the scalene, and the pectoral minor muscles are also going to contract. And that's going to cause a forced inhalation, which is going to inhale much more air than we would normally breathe during normal quiet breathing. And that ventral respiratory group is going to cause a forced exhalation response. Now remember, previously, exhalation was an inactive response. Relaxation occurs and exhalation occurs. But forced exhalation is going to include accessory muscles of exhalation, including external intercostals, external obliques, internal obliques, transverse abs, rectus abdominis, etc. And that results in the forceful exhalation. So the ventral respiratory group is only involved in forceful inhalation and forceful exhalation by calling in accessory muscles of inhalation and accessory muscles of exhalation. All right, so we also have some cortical influences, which allow us conscious control of respiration. That means that if we're going to smell something that we think might be noxious, we can hold our breath until we get to a safe spot. Or if we are underwater, we can choose not to breathe at that time. And that's going to be under the cortical influence. We also have chemoreceptors. We have chemoreceptors that are central chemoreceptors and peripheral chemoreceptors, and these guys are going to monitor your levels of both oxygen and carbon dioxide and provide constant feedback or input back to those respiratory centers. Now again, control of respiration is going to be found by these respiratory centers, right? So here we have these specialty receptors found in the carotid bodies of the carotid sinus. Here's the external carotid artery and the internal carotid artery, right? And at that region, we're going to have carotid bodies. Those carotid bodies are going to detect the concentration of oxygen and carbon dioxide. We're also going to have those regions here in the arch of the aorta found as aortic bodies, where they're also going to send information in terms of they're not just sending concentration of oxygen, they're also sending blood pressure, etc. There's a lot of different receptors that are found here, but these are going to send information up to the medulla oblongata, which is going to be, again, in charge of respiratory control. Now, if we end up with issues with the concentration of our carbon dioxide or our concentration of oxygen, that's called hypercapnia, hyper being increase and capnia being concentration of carbon dioxide. So a slight increase in our concentration of carbon dioxide as well as our hydrogen ions is going to stimulate central chemoreceptors to help increase our rate of respiration. Additionally, hypoxic conditions can do this too. It's an oxygen deficiency if we have a low partial pressure of oxygen in our arterial blood, again, as detected by these receptors found in the carotid bodies or the aortic bodies. That can actually also increase our rate of respiration. And sometimes this can be caused by high altitude, or can be caused by airway obstruction, or can be caused by fluid in the lungs. And again, control of respiration is a negative feedback loop, just like any of these feedback loops that we talk about. It starts by disrupting a homeostatic condition. In this case, we are increasing arterial blood carbon dioxide, or we could decrease our blood oxygen levels. Either one of those would result in a change that would need to increase our respiratory rate. And so we would do that by monitoring through these peripheral receptors that are found in the aortic and the carotid bodies, and sending information into the chemoreceptors in the medulla, which is going to result in nerve impulses through the control center and the dorsal respiratory group in the medulla oblongata, which results in effector cells, again, those muscles of inhalation and exhalation that they are accessory. They might contract more forcefully and more frequently, resulting in hyperventilation. The goal of hyperventilation being to decrease your blood carbon dioxide levels, increase your blood pH levels, and increase your blood oxygen levels. And once all of that returns to homeostatic conditions, then we can go ahead and end this stimulus response pathway. Okay, so this is a summary of different stimuli that affect your breathing rates, including hyperventilation. And we can voluntarily hyperventilate. You see people do this before free diving, for example. That's going to be under voluntary control by the cerebral cortex. We can also have increase in our carbon dioxide levels in our blood, detected again by those peripheral or central chemoreceptors. And that's going to be stimulated by, again, a decrease in arterial blood. Going to be detected by those central chemoreceptors, whether we have an increase or a decrease. So if we're going to have increase of breathing rate, that's going to be because we have an increase in carbon dioxide. But if we have a decrease in carbon dioxide or a decrease in arterial blood, that's going to decrease your breathing rate and depth. All right. So increased activity of proprioceptors. Basically, if things are happening around you that are going to state that, again, proprioceptors are going to tell you where you are relative to your surroundings, that might increase your breathing rates if we are implementing, for example, our fight or flight sympathetic responses. Increased pain can also increase your breathing rates. Decrease in the blood pressure can also increase your breathing rate. So things that are going to decrease your breathing rate, again, are going to include voluntary hypoventilation or underventilation, so holding your breath. And again, that's under control of the cerebral cortex. Or if we have a decrease in our arterial blood below 40, that could decrease our breathing rate. If we have a decrease in our blood oxygen below 50, so if we end up really low, normally we're decreasing arterial blood oxygen from 105 to 50 would increase our breathing rate. But if we get really, really low, we can start decreasing our breathing rate. Or again, if we have nothing coming in from our proprioceptors, if we have a decrease in our body temperature, that can decrease our respiration rate, or a sudden cold stimulus can cause us to stop breathing, or apnea, short breathing stop. Severe pain can cause apnea as well, and sleep apnea is also something that can occur where you have a slight stop in your breathing while you're asleep. Increase in blood pressure can cause a decrease in breathing rates, and an irritation in your pharynx or your larynx by chemicals can cause a brief apnea, but then cause a decreased breathing rate because of coughing or sneezing effects. All right, so let's talk about exercise in the respiratory system for a little bit. So respiratory and cardiovascular systems are constantly under adjustment depending on how much oxygen your tissues are using, so we can give more or less oxygen to the tissues that need it. And as you might imagine, as we increase the intensity and duration of exercise, that's going to increase cardiac output, which is going to increase blood flow to the lungs. That's called pulmonary perfusion. And that's so that we can get the most amount of oxygen into our blood supply as possible. In fact, it can increase up to 3-fold during maximal exercise. And during that time frame, we have a greatest surface area available for oxygen diffusion. This is why exercise is very, very important, because you want to make sure that you're able to get this increased 3-fold capacity the next time that you do exercise. And if you don't exercise often enough, you might have a decrease in the increase, if that makes sense. You might not increase as much as you could if you're doing regular physical activity. This slide is going to talk about the development of the respiratory system. As I've told you previously, I'm not going to test you on development, so I'm going to go ahead and move on. This slide talks about aging in the respiratory system. So as we get older, we have a decreased vital capacity, which is just our normal breathing, an increased blood oxygen level, a decreased macrophage activity, so we can end up with respiratory infections more frequently, or they might be more severe. And our cilia can decrease their action. So our respiratory epithelia can have less cilia, or their cilia can move less, which means that elderly people are more susceptible to various respiratory diseases, such as pneumonia, bronchitis, emphysema, which is typically caused by irritation, such as cigarette smoke, etc., long-term exposure to irritants in the respiratory tract, and other respiratory issues as well. So that brings us to the end of our lecture, and I really appreciate you sticking with us to the end. Thank you very much, and aloha. Happy studying.